I'll turn. Okay, so welcome everyone to our third session of our 2021 Virtual End Epilepsy Statewide Conference Education Series. Tonight's session is called EEG, A Patient's Perspective, and our speaker is going to be Marcia Ferguson. And I'm going to give a little intro for her, and then I'll turn the floor over to her. So in 1999, Marcia's 4-year-old developed absence seizures, and at the time, she was not aware that she was in status epilepticus. It took several trips to the pediatrician for the doctor to realize that she was having seizures. After visiting a neurologist, they received a diagnosis. As a young parent having a child diagnosed with something so life-altering, it caused everything to change. The information available for families was scarce, and a lot of unknowns made the situation very scary and unsettling. The medications were the best at the time, but did not control her seizures. There were and still are many uphill struggles. So after Marcia received her degree in psychological science, she found the neurodiagnostics field. Her passion is to assist patients with seizure disorders and receive professional care that adheres to the guidelines for EEG to provide the most accurate information so the patient may have the best possible quality of life. She attended Vanderbilt University's Medical Center's Allied Health Neurodiagnostics program, where she was exposed to many different aspects of the neurodiagnostics field. Prior to graduation, she was hired by Monroe Carroll Jr. Children's Hospital at Vanderbilt, and having been a parent whose child was seen in this very setting, solidified her desire to find a way to assist patients in finding the best care and answers. Currently, she works in an education and support role at Lifeline Neuro, a company that provides the systems and solutions for EEGs. Marcia believes it is vital that the patient and their families receive the care they need. So our session tonight is going to hopefully answer a lot of questions that you might have about EEG and just kind of give the basics from a patient's perspective, what you're walking into when you get an EEG. So I'm going to go ahead and turn the floor over to Marcia and let her take the floor.
Hi, thank you. Hi. Thank you guys for having me. I'm very happy to come in and share my story. It's extremely important. So my experience with epilepsy, as you heard, I had a 4-year-old that began having seizures and didn't know what it was, went to the doctor, didn't get a lot of help. It took a while for me to convince them that something was wrong. So it's important for me to tell my story to help others understand the facets of epilepsy and seizures and how they impact one's life. The diagnosis of epilepsy is like
Marcia, you're cutting out again. I'm sorry.
Patient and the families. It is important to understand that individuals and families deal with seizures as part of their daily lives. And a support system made up of family and friends. Is that better? Can you hear me? Yes?
Yeah, yep.
Okay. So having a support system made up of family and friends and people in support groups that have the same issue is extremely important. And resources like the Epilepsy Foundation helps provide information for those families. So my oldest daughter, who's now an adult, like I said, 4 years old, she started staring off in this face, and it looked like she was daydreaming. She was no longer able to say her ABCs or feed herself without dropping her spoon. And it scared me, the doctor, and it took me 5 appointments before they would send her to a neurologist, before they would actually believe something was going on. I was being told that she wasn't eating enough or she wasn't. So I finally got her into a neurologist, and they did an EEG, and they put her on Tegretol, which it did not control the seizures. We had multiple issues with medications. They only did monotherapy, so only one at a time. And then they gave me a few pamphlets to read, which is not very helpful. Eventually we did go to Vanderbilt Children's Hospital, where they also led to, she had a lot of social issues as well. There was a lot of issues in school and dealing with her peers. Her teachers were not very familiar with absence seizures, so I was having to educate them. Can you hear me?
Well, now we can. So
Okay.
I'm not sure exactly what's happening.
I don't know either.
Shoot. So could I ask Marcia if, while we would love to see you as you speak, what if you try turning your camera off to see if
Sure.
that helps?
Absolutely. Is this better?
So Marcia,
Well, we'll try it.
Marcia, do you want to send me your PowerPoint so that I can share my screen?
Sure, absolutely. Sorry about this, guys.
It's all right.
We hate this for you.
Make it this.
While we're waiting, as we go along, if you all want to put questions in the chat box, we'll be sure to have a Q&A at the end, and you can ask Marcia the questions, or I can ask for you depending on what you'd like. But we'll also have a Q&A at the end of the session where people will be invited to ask questions. But hopefully we'll get this back on the road in just a second, and I will I'll do Marcia's PowerPoint for her, or I'll let her talk while I forward.
Why you flip for me? Yeah.
And also, while we wait, I'll let you know about tomorrow's session. We have a special session for our seizure first aid certification tomorrow evening at 6:30. And then on Wednesday at 6:30, we are having our session on psychogenic non-epileptic seizures. So those are the next 2 sessions coming up. And so go ahead and mark your calendars and prepare to, or plan to attend those if you'd like. The more people we have on, the better.
The PowerPoint's going, so hopefully it'll be there in just a moment.
Okay. Well, if you want to just you might want to just tell your story again, because you did cut out a little bit.
Okay, sure.
Yeah, while I wait. Okay, good.
Sure, we can do that. So I'll start back from the beginning. So it's important for me to tell my story to help others understand the facets of epilepsy and seizures and how they may impact one's life. Sorry, I'm trying to make sure. Did you receive the PowerPoint?
I have not. Try to share your screen without the camera on.
Okay. Can you see it?
Yep, perfect.
All right, good.
All
We'll do
right,
that.
great, that works.
All right,
All
sorry,
right,
guys.
good, no problem.
Technology.
Yep,
Okay.
all right, we're ready to
So
go.
Marcia, would you go ahead and start over then sharing your story, and then we can get into the presentation?
Sure,
Since
absolutely.
I think that it's been resolved now, hopefully.
Okay, good. All right. So the diagnosis of epilepsy is changing for the patient and their families. It's important to understand that individuals and families deal with seizures as part of their daily lives. My 4-year-old began having absent seizures, and it took a while for us to get the doctor to understand that that's what was going on. She would stare off into space, and it looked like she was kind of daydreaming. And she was no longer able to say her ABCs. She could no longer feed herself. She kept dropping her spoon. And as a young parent, I was terrified. I had no idea what was going on. She had been perfectly healthy before. She had no previous illness other than, normal, like a runny nose, just a cold. So I scheduled the appointment to go to the pediatrician, and it took 5 more appointments for the pediatrician to understand that there was something going on. I was being told that she was not getting enough sleep, or she was not eating properly, or that she was faking it, that there wasn't actually anything going on at all. So he finally agreed to send her to a neurologist, where he scheduled her for her first EEG. And then they put her on Tegretol, and they gave me some pamphlets to read. So there wasn't a whole lot of information. This was in the mid-90s when she was diagnosed. The information was very limiting, and they eventually sent us to Vanderbilt Children's Hospital. Her monotherapy never actually controlled the absent seizures that she was having. We did multiple medications, multiple dose levels, and we still could never control her absent seizures. This led to a lot of social issues as well. Her teachers in her elementary school did not have a great deal of exposure to absent seizures, and it was difficult for me to help them understand that she's missing information when she's having her absent seizures. And she was also having issues with her peers, dealing with the other kids in her group because she was different. As a teenager, unfortunately, the social and psychological issues increased. Around age 13, she began having generalized tonic-clonic seizures, which completely left her debilitated. She was taking Keppra, and then also now Abilify, because she was also seeing someone for her behavior. And they were saying that she had a disorder, multiple personality disorder, depression, schizophrenia. They would never give her any of these, but they said this was also likely that what was going on. And none of those diagnoses were actually what was going on. She became very angry dealing with the issues with epilepsy. She became dangerous and began doing self-harming practices. Her therapist and the neurologist could not agree on what was causing stuck at the top of her head. She needed to drink more water. There's nothing wrong. One would blame the other for the reason that this was happening. Stopping the Abilify actually finally stopped the side effects, but there were still many issues to address. Her behavior became so problematic, and her self-harming behaviors herself, and then we were worried she was going to hurt someone else, that we had to have her removed, and she was put in a level 4 mental health facility to deal with the issues that she was having. in order to keep her protected and keep her safe. As an adult, controlling her seizures by taking her medications when they were scheduled and eating healthy and sleep hygiene became extremely important. But as a young adult, unfortunately, that's not exactly what's first. That's not what you're going to do, you know, being a young adult, being out on your own, wanting to have fun. She was in many unsafe behaviors and dangerous situations. And there were several times where she would have seizures and be unconscious and completely unaware of what was happening to her. Of course, being grown herself, she wouldn't listen to her mother. So we still had multiple issues that we had to deal with. Now that she's in her late 20s, her seizures are actually under control, and she's in a more stable existence and taking her medication and doing like she's supposed to do with age helped her to grow. So that's just kind of like a little bit of background on my experience with epilepsy as a mother, and then also going into the field to become a registered EEG tech. And so now I want to go over my presentation about what is an EEG and kind of what to expect when you go in to have an EEG. I think a lot of times people are told that you're going to come in and you're going to have an EEG, and most people don't know, especially if it's their first one. They don't understand what the process is and what's actually going to occur. Can everybody still hear me okay?
Yes.
Good. Good.
Yes.
Okay. All right, so what is EEG? So EEG is an abbreviation for electroencephalogram. It's understandable why they would want to shorten it to EEG. The first EEG recording was July 6, 1924, during neurosurgery by Hans Berger. An EEG is a test that allows the doctor to see a snapshot of how your brain is functioning or how it's working. Whereas an MRI gives a picture of what your brain looks like. The EEG allows the doctor to see a visual representation of waveforms and a pattern on a monitor screen of the neurons and the nerves in your brain as they are talking to each other. Did you know that depending on the state that you're in, awake or asleep, your neurons will create different patterns on the EEG? If you're awake, asleep, reading, or having a seizure, these patterns all look different. And your doctor and your EEG technologist know what these patterns represent. A couple of things to know about an EEG. The EEG technologist cannot read your mind or know what you're thinking. Other than the placement of the electrodes on the scalp, you should not feel anything. It should be a pain-free application experience. Depending on the length of the test your doctor has requested, which will be discussed with you before the test, will determine how long you will have to wear your EEG. Your doctor may request that you stay up later than usual. They call this being sleep deprived. During an EEG, the tech will attempt to capture multiple states, such as awake, drowsy, and asleep. Sleep is very important to try to capture during an EEG, especially in children. Sometimes there's activity happening in the brain that is easier to see during sleep. This gives the doctor a broader picture of what may be occurring in the brain. Being sleep deprived increases the chance that you will sleep during your EEG. The doctor may ask you to refrain from caffeine and sugar prior to your test. Any directions concerning your medications should be communicated to you, the patient, directly from your doctor. It is advisable to bring all your medications with you. Your technologist will make a note of these medications you are taking, the amounts and the times in your EEG notes section. To make the process of hooking up the EEG faster and more pleasant, the patient will be asked to have clean, dry hair that is free of all products like hair gel, hairspray, oil, or leave-in conditioner. Wearing comfortable clothing and ensuring to use the restroom before the start of the EEG application are also beneficial in making the test a more pleasant experience. It is also encouraged, if the patient is a child, that he or she brings toys or blankets to assist in making the child feel more secure and comfortable during the procedure. Bottles, drinks, snacks, and entertainment, such as their favorite cartoon to help watch during the hookup, may help distract from the application process. When it's time for your appointment, whether you're in the home, the clinic, or the hospital setting, the technologist will ask a range of questions. The answers to these questions will assist the doctor in seeing the whole picture of why you're having an EEG. Questions such as, tell me what your events look like. When do these events take place? Is this the first time this event has happened? If not, when did they start? What do you feel and remember when you're having these events? If the patient is accompanied by someone, they may be asked to give a description of what occurs during the events. Or is there anyone else in the family that has these events? Or is there a history of epilepsy in the family? Or has there been a recent fall or previous injury? The technologist will conduct a brief history and record the medications that are currently being taken. The technologist may also inquire if hyperventilation is going to be done. That's the breathing exercises. If the patient has sickle cell disease, moyamoya disease, asthma, recent stroke, cardiovascular, pulmonary disease, or if there's any reason that's preventing the patient to do cardiovascular exercise. The technologist will explain the procedure of the application of the electrodes, the length of the study, and what to expect during the EEG, and the process for disconnecting the EEG once the test is complete. You may have your EEG conducted sitting up, in a reclining position, or lying in the bed, depending on where the test is being administered. To begin the electrode application process, the EEG technologist will measure your head to ensure that the correct electrode placement. This is a simple process, but extremely important in allowing accurate placement of electrodes. The 1020 system is the standard electrode placement and is based on the relationship between the location of the electrode and the underlying area of the cerebral cortex. This method was developed to maintain standardized testing and to help the ability to compare studies to one another. Your brain has many lobes or sections. There is a right and a left side of your brain, and each side is separated into several lobes. These lobes are frontal, temporal, parietal, occipital, and insular lobe. Neuronal activity in each of these lobes will present differently. Frontal lobe activity may cause someone to wake up at night and begin marching around. The occipital lobe activity may cause the person to see starburst. Temporal lobe seizures could cause fear and panic and experience deja vu. Parietal lobe seizures may present as heat, numbness, or electrical sensations. Insular lobe may present as suffocation, breathlessness, or taste auras. These are only a very few examples of how seizures may present themselves from the different lobes of the brain. Therefore, measuring a patient's head is extremely important. Ensuring correct electrode placements gives the doctor the location of the activity, which assists the doctor in determining what the best course of action will be to assist the patient. After the technologist has measured your head, they will begin to prep the area to apply the electrodes. This is typically done with a cotton swab and a small amount of scrub, which will clean the area of oils and dry skin to allow the very tiny electrical signals from the brain to transmit to the EEG system. This is a gentle process and should not cause discomfort. The electrode cup at the end of the electrode wire, which is connected to the EEG system. These electrodes may be left as is or there may be collodion, which is a glue to attach the electrodes. They also may use a gauze bandage or some type of wrap to secure the electrodes to the head. The wires will be bundled out of the way to prevent tugging on the wires and disrupting the connection to the scalp. A small amount of conductive paste will assist the transmission of electrical signals, is applied to the cup and to the skin after it has been prepped. Depending on the type of EEG you're having will depend on the number of electrodes used. The standard EEG hookup is referred to as the 1020 system, but additional electrodes may be added at the doctor's request. Once the hookup is complete, the technologist may begin the EEG recording. During the beginning of the recording and possibly throughout the recording, the technologist may conduct stimulation protocols or activating procedures to attempt to elicit activity. Hyperventilation may be conducted. This is a series of guided deep inhales and exhales for 3 to 5 minutes. To assist in the breathing exercises, the technologist may provide a pinwheel or a piece of tissue to help the patient conduct the exercise. Patients who have absent seizures may experience events during deep breathing exercises. You may experience being lightheaded during these exercises, these breathing exercises. This is a photic stimulator like the one I use. This allows the technologist to conduct photic stimulation, which allows the doctor to see how your brain reacts to flashing lights. This consists of multiple sequences of lights at different hertz, flashing approximately 30 centimeters from the patient's face. Your eyes may be open or closed or both during the photic, depending on the lab's protocol. The flashing lights may produce events that may be associated with seizure activity. Also, some patients may experience seizure-like activity that may need further investigation. Once the stimulation protocols have been addressed, the rest of the EEG may consist of trying to sleep, or in an epilepsy monitoring unit or ambulatory EEG at home to continue your normal daily routine, depending on the type and the length of study that you're having. During the study, you may be instructed to use the push button to mark patient events. Or you may be given a sheet of paper to document when you eat, when you sleep, your different schedules that you may be doing when you're taking your medications. And once your study is complete, the electrodes will be disconnected and you will need to wash your hair due to the prep gel, the conductive paste, or the collodion, depending on the type of EEG that was administered. The EEG will be sent to your doctor to read and determine the outcome of the EEG, which will guide the next steps in your journey's process. So EEG systems have come a long way over the years. Where it once was as large as a desk, now it's so small that you actually wear the amplifier. So an EEG is a necessary diagnostic tool to determine how your brain is functioning, and it helps your doctor determine the next steps for your journey.
So Marcia, are we ready to open the floor for questions, or
Sure, we can do that. Absolutely.
did you have anything else you wanted to add?
I only had some trying to find my document, sorry.
Oh, you're fine. If anyone doesn't want to ask a question face to face and would like to type it in the chat box, please do that. And I'll read them to Marcia at the end, or before we get off of here, I'll allow people to unmute themselves and ask questions.
So just kind of as a recap and some things to kind of help for daily life with a patient with epilepsy involves planning schedules to ensure medications are taken correctly and safety measures are implemented. So setting alarms for daily medication and attempting to be consistent with taking medications at the same time each day has benefits. Ensuring medications are taken and not forgotten. Sleep hygiene is a necessary factor. Acquiring the correct amount of sleep and quality of sleep assists in regulation of seizures. Setting appropriate and consistent night and morning routines to allow the patient to attain the correct amount of quality sleep. Maintaining a healthy diet and appropriate water intake. Avoiding stress and excessive amounts of caffeine and alcohol. There's value in obtaining exercise according to the patient's ability. Educating the families concerning SUDEP and precautions required for safety. Seeking out support groups and other patient resources. Being aware of your doctor's appointments and keeping them is extremely important. Our busy lifestyles may make it difficult to make and keep these appointments, but having regular check-ins with your care provider will provide invaluable information if changes are necessary to medications. And reporting any new types of episodes or changes will assist your doctor in assessing the situation and determine the steps that are necessary. Remember to take all of your medications with you when you go to your appointment. Some patients will keep diaries of their medications, their food intake, sleeping, and episodes with accounts of what happened or did anyone witness the events, because any additional information that may be available adds information pieces to the puzzle for the doctor. And it also may be important to collect additional family history. So if there's anyone else that has epilepsy in the family, or sometimes they may have been called spells or just different issues that until people start asking questions, nobody realizes that they may actually been some form of epilepsy. And then your physician should be able to assist in providing information for resources, and also like the Epilepsy Foundation. So there's so many more resources out there to help people than there was when I was going through the process with my daughter. So I hope you found this interesting and helpful, and we can take questions.
All right, well, thank you so much, Marcia, for sharing that information. I know that I did learn a lot about what the process was actually like. Would anyone like to ask a question? There's not anything in the chat box.
I have one.
Okay.
With hi, my name's Marcella, and I have what's known as I guess they're called pseudo seizures.
Okay.
And the question I have is, I've had my fair share of EEGs, and you've actually answered a lot of questions for me because I never understood them.
Wonderful. Good.
And I've actually, I remember all of the things back to 1910, so, or whatever there was. But one of the questions that I have that I never quite understood was with the strobe lights. That always, I never quite understood that. Why does that affect me? Because I do not have epilepsy, and I cannot have a strobe light. And every time that I get in front of a strobe light or anything, or every time they put that little light on, it just, yeah. But with me not having epilepsy, I wanted to ask that.
You said your diagnosis was pseudo seizures. Is that what you said your diagnosis was?
Because I've had, every time that they have done an EEG, And I've
Mhm.
also been in the monitoring units and stuff. They
Right.
have said that there's no seizure activity that's come up in the EEGs.
Right. So what is happening? There's there is an episode, you are having a reaction to the lights flashing. There's just not any cortical, so the brain's not reacting to it like we would see in an EEG. And typically, did they send you elsewhere to do some more research to kind of look into why you were having the episodes? No,
No,
not
they
yet.
just they've just pretty
Yeah.
much said and I'm on seizure medicine. That's what's weird.
Mhm. Yeah.
I'm on gabapentin, Topomax. I've been on Keppra. So
Right.
I'm on seizure medicine. They just said that you have pseudo seizures. So
Yeah. I would talk to your doctor to see if they have any other recommendations for you to further investigate why you're having those.
I just never understood the flashing lights. So I just wanted to ask.
Mhm. Yeah. Yeah. And so my daughter she would react to the flashing lights, and she would have her epileptic seizures during the flashing lights. But then, like I said, sometimes they just produce seizure-like activity, which is what it sounds like you're having. And usually they offer other, they may send you to a different type of doctor, maybe to some type of counseling to try to see if they can figure out if there's anything related to that and why you're having those episodes, to kind of like look further into it. So that's what I would suggest. I would suggest that you ask your doctor to maybe refer you to someone else so you can do some further investigation.
Okay, thank you.
You're welcome.
Anyone else?
Hi, Marcia. This is Deb, and I
Hi.
do have a question for you. So, and
Yes,
I
ma'am.
also learned a lot, even though, my daughter was diagnosed many years ago. But when you were showing the EEG, and there were the different lines, and
Okay.
there were the descriptions underneath each of the areas of the EEG. Can you go into a
Mhm.
little bit more detail of that part of the EEG and what those really represent then? Are they parts of the brain itself? And is that where the seizure, when it's picking up seizure activity, is that what it's showing?
So when there's seizure activity, there'll be either a spike or a wave. That's kind of what they call it. What you're talking about that you see with the 4 different waves, there are alpha, delta. Oh, I need to look at that slide. But so when you're awake, you have alpha. When you're drowsy, you may have theta or delta waves. Beta waves would be a higher frequency. So those are just different frequencies of waves depending on what state you're in. And your technologist and your doctor can actually just look at the graph and tell what types of waves, and they can actually tell if you're awake, if you're asleep. Are you in REM sleep? Are you in deep sleep? Are you in stage 1 or stage 2? So those are just the different waves that show up depending on what state your brain is actually in, what state you're in, awake or asleep.
Ah, okay. I did not know that. And then, so how do they determine what area of the brain the seizure activity is taking place in?
So that's where measuring and applying those electrodes, because it's going to show up in whatever electrode is on as where that electrode is placed. So if it's in the frontal, you'll see it. Those would be like the electrodes that are on the forehead. So if it's occipital, it'll be on the back of the head. So they can tell by where that activity is occurring in those channels, depending on where those electrodes are placed on the head.
Okay.
So basically, Marcia, is it that each of the lines is indicative of one of the electrodes placed on the head? And so you're able to look at each one of the line readings and determine different parts of the brain depending on where it's located.
Absolutely,
Okay.
absolutely. So, and we compare, so we can look at each channel individually, each electrode individually, or we also compare them to each other. And then that's where you can see the different waveforms.
Okay, I'm gonna put a picture up here real quick. Just to, hold on. So basically, maybe. So basically, this is a channel. This is a channel. So this is a different, each of these are different electrodes, correct? Where I'm
So
pointing arrow.
those are pairs of electrodes. So you have
Okay.
2 electrodes being compared to each other for each of those channels.
Okay, so like 2 frontal, 2 temporal. So each of these is a different electrode on the brain.
A different set of electrodes.
Okay, and so my question is, if somebody moves and there's no video on them to see if they're moving or not, how do they know the difference between a movement and a seizure?
So if there's movement, it comes up as muscle artifact, which is
Okay.
a lot faster, and the doctors and the technicians are trained to be able to determine what's muscle from just moving, and then
Okay.
what would be an actual spike or wave or
Okay.
blink. So yeah, you learn all the different patterns.
No, I watched a loved one while they were being, they were on a 24-hour EEG, and every time the person moved, I about had a heart attack when I'd see the waves
it's-
move.
Right.
And then-
It looks the muscle activity, we say that it looks kind of angry, because sometimes there's be so much, it kind of goes black almost.
Yeah, it looked angry. It scared me
Yeah,
at
it looked
first until I
scary,
realized
yeah.
it was movement causing it, and I just
Yeah,
didn't know how they
yeah.
told the difference. Okay, thank you.
So they're trained to tell actual patterns and waves from muscle artifact. Yeah.
Okay.
So,
Thank you.
and then, so Marcia,
Uh-huh.
when, for Victoria, for example, I think that they said that she had 3 spikes per second, so that they were identifying the type of seizures that she had, which were absence seizures. So are there
Correct.
there are different patterns for the different types of seizures, correct?
Correct.
Okay, so, and when the doctor says that that a person has simple partial or absence or generalized seizures, so there'll be a pattern on the EEG that will then represent that particular type of seizure activity.
Correct. And it also has to do with location. So a generalized would mean that it would happen all over the brain. But if they're having a partial, it may be in just one location in the brain.
Okay,
So, right. So there's different types, and then the location of the seizure also ties
Okay.
into the naming of the seizure. Yeah. The type of pattern.
okay, great, thank you.
Any other questions?
Yeah, just to elaborate on kind of what Deb was asking with the wavelengths or what have you. So just something, the difference, so when somebody that has epilepsy, the wavelengths is showing up, right? And then somebody like me, that's how they can tell the difference. Is that what I'm guessing?
Exactly.
Because that's something
So
that my daughter just asked me to ask. She's
Okay.
like,
it
'cause she
does.
said
It
that's
looks
something
different.
she never understood either.
Yeah. So if you're having a psychogenic seizure, you're going to see a lot more of that muscle artifact, but you're not going to see the spike and wave patterns or the sharps like you would if it was cerebral epileptic activity.
Oh,
So it
okay.
looks different.
Oh, okay. That makes sense. Okay.
Mhm.
Because it's more muscle than more brain.
Correct.
Gotcha. Okay. Okay.
Correct. And I'm sure when you've had yours, they probably did some testing. They probably asked you a bunch of questions. like where, you know, what's your name? Were you able to respond to their questions when you were having your episodes? No.
No, I
Okay.
did the button where like the one you was talking about, the button one and everything.
Uh-huh.
I did that kind.
Okay.
And in the thing where I had to press a button if I felt like I was going to have a episode, I had to press a button,
Okay.
or if I felt anything. And then I also did one at home too. I'd been in a hospital and I also had to do one at home, but they're wanting to do another EEG on me, so I don't know why. I'm like, doesn't make sense.
Well, you know, sometimes, unfortunately, like if you're only doing like a 20 or a 30-minute EEG, you might not catch everything. And sometimes you might not catch anything. So sometimes they'll want to do longer ones, like have you stay in an epilepsy monitoring unit where you stay overnight or
Yeah.
for several days.
Yeah,
Yeah.
I've been in one where I was in for like couple days.
Mm-hmm. Did they have you like ride an exercise bike or stay up late and not sleep?
They had me sleep deprived, eat deprived, like all of that.
Right.
I was like, I
Yeah.
was so tired when I got out of there. I was like, I want to go home. It's like I felt like I'd been kidnapped. I was
Yeah.
like, just let
Yeah.
me go home.
Oh, I'm so sorry. Yeah.
I
Yeah.
felt like a lap rat when I got out of there because they had done so much to me. I was like, just let me go
Yeah.
home.
Oh,
But
I'm sorry.
I don't understand what more they could do. I that's just what I don't understand. So
Yeah.
I just wanted to ask questions. Sorry.
No, you're absolutely fine. Ask all the questions you need to ask. Yeah, so like I said, sometimes the tests, they may not be long enough, or they may think that, or they may want to try and reduce medication. They may want to see if you need additional medications. So that's why you're having continuous EEGs, because we change, you know, our when we're kids to adults, we change, you know, just as adults, as we get older, we change. So that also causes changes in your, you know, brain function. So that's also a possibility why they're continuing to have EEGs done. They're looking
Okay.
for changes. Mm-hmm.
Okay, we have a question in the chat box, Marcia. It's the person asks, for an EMU stay, does it matter how you have your hair fixed? Like, for example, would 2 French braids affect the electrode placement?
So the electrodes should always be in the same place. If the braids are loose, you may have a tech that can work around them. If they're really tight to the scalp, that may cause issues if the braid is where the electrode needs to be. So with the electrode, you need to be able to get through the hair and to the scalp to make sure it's attached properly.
So what would you think as an EEG technician, what would the best hairstyle to come to the EMU? Like what state would your hair be in aside from clean and not with product?
Right, clean, dry. Probably, especially if you have longer hair, just brushed out, free of knots or tangles or anything like that, and just in a ponytail, and the tech will end up taking it down to do the measurement and then the electrode placement. And then I've also seen some, especially in the EMUs, the techs will actually like braid the hair. And I used to put the little kids' hair, you know, like in ponytails to help them so they'd be, it would be out of their way, but then it'd be more comfortable for them to sleep, you know, on it. So most techs will help get the wires and the cords and like I said, braid your hair, put your hair in ponytails, but clean, dry hair, free of tangles. That way it makes it just for an easier application.
Gotcha.
Yeah.
There's another question. Can the time change affect your meds or results in an EEG? Like if it throws your sleep cycle off?
I would go to your doctor and ask that question. That would probably be a good question for your doctor. Consistency is usually important when taking your medications, taken at the same time every day. But I would address it with the doctor to see if they had any advice for that. I wouldn't want to give medication advice, but yeah, taking, you know, consistent, taking it at the same time every day is usually the pretty standard.
Thank you. Anyone else?
So Marcia, is
Okay.
there a product or something that you recommend once the EEG is done and then it's time to remove the electrodes? You go home, or if you're at home, and what product or products do you recommend in getting the glue or the
Out of the hair.
materials?
So
Yes.
if it's been yeah. So if it's been a collodion hookup, which is the glue, it has a very strong smell, and then the smell kind of goes away. I don't know if you're familiar with that. Lots of conditioner. They have a collodion remover, which is kind of like an oil. So oils kind of help, olive oil, baby oils, that type of thing. Lots and lots of conditioner. We always recommended that they use conditioner first before washing the hair, to kind of help break it up, kind of make it softer. Also, we would use acetone to remove the collodion, putting a little bit on a Q-tip and doing it in just in the spots where the glue, that will help also remove it. But lots of conditioner, especially if you have a lot of hair.
Thank you.
You're welcome.
Well,
Hey, Marcia, I'm going to ask her a question. I have a daughter, Allison, who's had numerous EEGs. And when she's hooked up and I'm sitting there staring at this monitor, not knowing what I'm looking at, she'll be sound asleep or not, not moving, awake, alert or whatever, but sitting nice and calm. And it keeps on coming up as extra large spikes. Are those like questionable, like where there's like a seizure activity kind of, but it doesn't amount to a seizure? Or
So how old is she?
she's now 22.
She's 22.
So, but she's
Okay,
had seizures
so-
since she's been 5 and still having them. So.
Right, exactly. So a child's EEG, the amplitudes of the waves, they're larger. So sometimes it looks a little bit scarier because they are bigger. That's just how it is. Adults
Okay.
are smaller, so it doesn't look quite
Right.
as scary. So that may be what you're seeing. A lot of times in sleep, especially in children or younger adults, that's when you can see, depending on the type of epilepsy, that's where you can see a lot of activity. That's why it's so important
Right.
for children to sleep during their EEG. With me being a tech, I wouldn't want to comment on what it is, especially,
Yeah.
not
Well,
seeing it. We
yeah.
always refer that to the doctor.
Well, I know and I'm sure it could be interictal spikes kind of thing, but it'll come up and it'll be like, she
Right.
didn't move. And then I'm looking at the waveforms going, which one of them looks different than it did a second ago? And by then the screen's changed and we're on to the next screen. So, that's all. I was just wondering if you could.
And just because she's still and she's asleep doesn't mean her brain's not going. Our brains.
Oh,
are
I
always
know. Oh, yeah.
Yeah.
We've had many seizures while sound asleep. So I get it. But, yeah.
So yeah.
So, thank you.
You're welcome.
all right. Anybody else? Well, Marcia, I want to thank you so much for this amazing session. I really learned a whole lot, and I feel like from an education standpoint at the foundation, I feel like I will be able to better talk about this subject when I'm doing presentations for schools and for different groups. So just to explain a little bit more about what's going on, not necessarily the deep dive we did tonight, but thank you so much. And thank you everyone for attending tonight. Like I said, tomorrow's session is going to be the Seizure First Aid Certification Program. If you are interested in that, please send me an email and let me know. We need to send you some pre and post survey information. Also, the next one will be on Wednesday, and that's psychogenic non-epileptic seizures. So that one's at 6:30 as well. So I will keep sending out reminders. So hopefully you all will keep coming, but I really appreciate you being here tonight. Marcia, thank you. Please let people know if they are having questions about this session. It is going to be on our YouTube site probably tomorrow. So all right. Thank you, everyone, and have a great rest of your evening. Okay. All right,
Thank
bye-bye.
you.
Thank you for being
Bye.
patient with my technical
Bye.
difficulties. Yeah, have a good
Oh,
night.
that's okay. It's fine. Bye. It worked out all
Bye.
well in the end.
Bye.
Take care. Thank you so much, Marcia.
You're welcome. Bye.
Bye.
Bye.